So I'm going to be talking to you today about atypical femoral fractures and what's so atypical about femoral fractures. So I'm a musculoskeletal radiologist and I work in Toronto at Sunnybrook, and I have interests in a lot of different aspects of musculoskeletal imaging. I pretty much do 100% MSK, and this is one of my areas of interest, and you're going to see why. I'm going to show you sort of a case example as why this became an interest of mine. Okay, so I don't have any disclosures. So today we're going to understand the case definition of atypical femoral fractures, which is key to understanding the imaging appearances. We're going to talk about the multimodality imaging appearances of atypical femoral fractures, and we're going to talk about the treatment and hardware complications. Okay, so I want you to have a look at this case. So this is a 78-year-old female who was in the emergency department and presented with hip pain, and the clinical history we were provided with was hip pain, rule out OA. These x-rays are there for you just to have a look at. So I want you to just have a look and see what you think here. Where's the most significant abnormality, or are these x-rays normal? How would you report those? Okay. So I'll just give you a moment there. We're going to revisit this a little bit later, and this is one of the cases that sparked my interest in this topic. I just have another question for you to think about as we go through this talk. How is this fracture likely to be treated? DHS fixation, an intramedullary locking femoral rod, lateral side plate, a total hip arthroplasty, or conservative with no weight bearing? Okay, so just have a look at that. Again, we're going to revisit these at the end of the talk. So I'm just going to tell you a little bit about the pathogenesis of atypical femoral fractures, because this is important to understanding why they occur and the imaging appearances. So bisphosphonates are anti-resorptive drugs that are used to decrease the risk of osteoporotic fractures. You know, they're very commonly used. I'm going to give you some statistics about how frequently they're used. But essentially what they do, bisphosphonates, they work here. So that's an osteoclast, and there's the bisphosphonate. So it inhibits osteoclastic resorption of bone. So that's kind of the main function of bisphosphonates, and therefore it decreases the risk of osteoporotic fractures. Atypical femoral fractures are also associated with other drugs, not just bisphosphonates. So another drug would be denosumab, and that is a drug that actually inhibits osteoclasts themselves. So not the function, but actually decreases the formation of osteoclasts. So those two drugs are, we know more commonly, the bisphosphonates. So as I mentioned, bisphosphonates inhibit the osteoclastic bone resorption. And in normal bone, the remodeling really is a combination of the bone resorption and bone formation. And that process is really coupled together. So when we give bisphosphonates, we're disrupting that normal bone turnover process. And normally what happens is when there's bone that's resorbed, it triggers bone formation. So that's sort of the cycle that continually happens over and over again. But now we're reducing the bone resorption, and therefore the bone formation also decreases. So that is uncoupled. The normal process becomes uncoupled. So bisphosphonates are the most widely prescribed osteoporotic drugs in Canada. So here's just some stats for you. So the number of prescriptions dispensed by retail pharmacies in 2011, just look at the numbers, it's huge. So these are very highly used drugs, and it costs about 2.2% of our total drug expenditures. So these are really commonly used drugs for osteoporotic fracture reduction. So what happens is now we're suppressing the bone turnover, we're suppressing that normal remodeling response by giving the bisphosphonates. And this is just to show you here normal bone on the left and osteoporotic bone on the right. So you really lose that normal architecture and trabecula, and you lose those sort of spicules of trabecula in a normal osteoporotic bone. And then what happens when this uncoupling happens is that there's little micro cracks in the bone. And you can see that this bone's probably not very strong compared to normal bone. And then they develop these little micro cracks, but because it's been uncoupled, the bone resorption and formation, they get these little micro cracks, but there's stimulus to make new bone has been reduced. So that's what happens. So that's why we get these atypical femoral fractures. So who's at risk for this? Well, there is definitely a category of patients who are at risk. So females, and it's probably because females are more likely to have osteoporosis and they're more likely to be on these drugs. So there is a risk for being female on that. If there's concomitant steroid therapy, that also would increase the risk. And interestingly, Asian ancestry has been shown in different studies to have increased risk, and the cause for which is not totally clear yet. But here's just a study by Marcano in 2014 that identified, they had 54 patients, and 17% of them were Asian. So that was just an interesting fact that they don't talk about why, but it's just an interesting fact. And I can tell you that we have, there's an Ontario registry for atypical femoral fractures, and the main sort of hub of that is at Toronto General, and that's where I have a lot of the data that I've been working on some projects. And definitely there is a higher incidence of Asian population in that group. So it's interesting to note. We don't know if it's something to do with biomechanics or if there's something to do with DNA, that kind of thing, but it's not totally clear yet. This study that I'm showing you here suggests that Asians are at higher risk for atypical bisphosphonate-associated fractures, and they do recommend closer follow-up in the Asian patients who are taking bisphosphonates. So that's just an interesting fact. I'm just going to talk to you a little bit about some of the background and how this came up, because I can tell you when I was a resident, I didn't know any, this was not, I'm not that old, by the way, but this was not something I learned about as a resident. So this is new. Like, there's not a whole lot of new stuff that happens in musculoskeletal imaging, but this is definitely something that's come up in the recent past. And in fact, 2005, I don't know if you can see in the bottom there, was when this started to really kind of come to light that there was a problem or something was going on. So this paper here, severely suppressed bone turnover, a potential complication of alendronate therapy. So just in the highlight there, we report 9 patients who sustained spontaneous non-spinal fractures while on alendronate therapy, 6 of whom displayed either delayed or absent fracture healing for 3 months to 2 years during therapy. So that was a report, first one of 9 patients. So of their 9 patients there, 4 of them had femoral fractures, 2 were bilateral. So the findings of this study raise the possibility that severe suppression of bone turnover may develop during long-term alendronate therapy. So that was the conclusion of that study back in 2005. Here's some other studies. So this is from JBMR, and this graph here on the left is really showing the bisphosphonate use. So you can see over time the bisphosphonate use has increased. The upper line is the women versus men has remained relatively stable, but definitely has increased in women. And the just graph on the right there is looking at the bisphosphonate use and the trend for increasing subtrochanteric hip fractures. So this was going up in a very similar fashion over time. So this definitely sparked some interest. And so in the context of declining typical hip fractures, so those ones were getting better, the good news, the typical ones were getting less amongst the US elderly, they observed a small but significant increase in incidence of subtrochanteric fragility fractures. So they estimated that for every 100 or so reduction in typical femoral fractures, there was an increase in 1 subtrochanteric fragility fracture. So doing good things, but at the same time, there is this risk. Here's just another study. This is from JAMA in 2011. And this is just showing you here, so the bars are showing the purple to the left is the femoral neck or intratrochanteric fractures, so the sort of typical fractures. And then the yellow is the subtrochanteric. So you can see, and this is the amount of time on bisphosphonates. So as they were on bisphosphonates, the typical femoral fractures were going down slightly, but these atypical or subtrochanteric, they weren't called that at the time, now we call them atypical femoral fractures, were going up. Okay, so but having said all of this, the absolute risk for atypical femoral fractures is low. So among women with at least 5 years of bisphosphonate therapy, the risk of subtrochanteric or femoral shaft fractures in the subsequent year is 0.13%, and within 2 years is 0.22%. So we are definitely seeing a high prevalence of bisphosphonate use in atypical femoral fractures. But the absolute risk of atypical femoral fractures with bisphosphonate use is low. So 2,000 users for 1 atypical femoral fracture. So the bottom line here is the use of bisphosphonates outweighs the risk of having an atypical femoral fracture. So we just need to be vigilant, be aware of this, and do a few things I'm going to talk to you about the management so that we minimize some of the negative outcomes here. So atypical femoral fractures represent 1.1% of femoral fractures. It's an uncommon complication of bisphosphonate use, and the bottom line here is the benefit of the bisphosphonate outweighs the risk of atypical femoral fractures. So we still use bisphosphonates despite this. But now what we need to do is be aware of this and make sure they're treated properly. Okay, so now I'm going to talk about the ASBMR, the American Society of Bone and Mineral Research, case definition of atypical femoral fracture. So what happened is when this whole thing came to light and they realized what was happening, a large working group came together to really talk about what are these and how do we define them so that we can all call them when the right thing and we can be aware of them and really have a clear definition of what these are. So they came out with the original version and then they revised it in 2014. So this is the definition of atypical femoral fractures, the most updated one that was revised. And you can see there the reference if anyone's interested in looking at more of the details. It's a very long document. I've just picked out the important things that I think would be pertinent for you to be aware of. So there are major features, and you have to have 4 out of 5 of these major features to be called an atypical femoral fracture. So one is minimal or no trauma. They usually present with just sort of generalized pain or aching, that kind of thing, and some of them are asymptomatic, but they have minimal or no trauma. The fracture line has to originate at the lateral cortex, and it is substantially transverse in orientation, although may become oblique as it progresses medially across the femur. I'm just going to show you a picture of that here. So it starts at the lateral cortex, and it's transverse through the lateral cortex, and then it becomes oblique as it progresses through to the other side. This is, of course, a complete fracture. They're not all complete, as I'm going to show you examples in a minute. So the next thing is that complete fractures extend through both cortices and may be associated with a medial spike. So what that means here is you can see there's a spike there. And the spike could go up or it could go down depending on how the fracture progresses across the femur. So it can also go down, so you could have a medial spike going inferiorly. Incomplete fractures involve only the lateral cortex. So here's an example of an incomplete fracture, and you can just see there it's only involving the lateral cortex. So if you just see it on the medial cortex, it's not an atypical femoral fracture, or not by the definition in any case. These fractures are non-comminuted or minimally comminuted, and I actually only have one example of a minimally comminuted one to show you, and they've already been fixed. So you can see there it's a little bending wedge fracture there. So that's my only example I have of a minimally comminuted. All the rest I've ever seen are just simple fractures, non-comminuted fractures. Localized periosteal or endosteal thickening of the lateral cortex is present at the fracture site. So it forms this beak. So you can see there's a lateral beak there. So that's really a classic appearance, of course, of an incomplete fracture. And you can see how it also causes a little bit of thickening on the endosteal side as well. So that's sort of the classic incomplete atypical femoral fracture. Okay, so those are the major features. So you have to have 4 or 5 of those to call it an atypical femoral fracture. Now there's also some minor features, and here's one, which is generalized increase in cortical thickness of the femoral diaphysis. So you can look here and you see there's just this sort of length of the cortex that's thickened, and it often is sort of undulating as it's thickened. Here's just another example there of just some diffuse sort of cortical thickening there. So if you were to see that, you would definitely raise the clinical question, is this patient on bisphosphonates? They present with unilateral or bilateral prodromal symptoms, such as a dull or aching pain in the groin or thigh. Minor feature. Another one is that bilateral, incomplete, or complete femoral diaphyseal fractures. So when they're bilateral, it certainly raises the suspicion of an atypical femoral fracture. So you can see here's an example. There's a bone scan there showing the bilaterality, and not so obvious on the plain films, but the bone scan in this particular case, I'm going to talk a little bit more about that later, but certainly helped identify the site of abnormality here. Here's another example of a bone scan showing bilateral uptake, and you can see here is some plain film. There's a plain film, and this on the right side, it's got that diffuse cortical thickening, but the bone scan really helps to identify the site of abnormality, and the same thing is happening on the left. So fractures are bilateral in up to 60% of patients. So this is the key finding as well, or key point. We did a project, we published it in Skeletal Radiology in 2015, and I'm very lucky to be part of this registry that we have in Toronto, because we had a lot of patients with bilateral atypical femoral fractures. And in our study, we had 78 patients who had bilateral fractures. I think there's over 300 patients now in the registry. 58 of these, so 76.3%, had bilateral fractures within 5 centimeters of each other, and those are the blue lines there that you can see where they were within 5 centimeters, and then 41 out of the 70, to be 78, so 53.9% were within 2 centimeters. So quite a number of them are very close together from right to left. And so most atypical femoral fractures occur within 5 centimeters of each other. So that's an important finding as well. So you want to make sure you image both femurs. That's definitely a key as far as us as radiologists helping and guiding the clinicians, because if we see it on one side, we definitely want to suggest that the other femur is imaged, given this high incidence of bilateral fractures. So another minor feature is that there's delayed fracture healing. Okay, so remember that the bone turnover resorption is not the same as normal, so there's definitely delayed fracture healing, and this can be a problem because they lead to hardware failure and that kind of thing. So they definitely need to be closely monitored, and as far as typical post-operative processes, as far as weight bearing, et cetera, they really need to be monitored a little more carefully than the typical fractures. So in their case definition, they've specifically excluded certain fractures. So they've specifically excluded fractures of the femoral neck or intertrochanteric fractures. So those are kind of your classic femoral fractures. They exclude pathologic fractures, and they also exclude periprosthetic fractures. So interesting on that last point, because here's a case we had. Here's June 2011. The patient has a total hip arthroplasty, you can see there. 2012. Boy, that looks like an atypical femoral fracture to me, just from what I showed you. And then just later on, they've gone through to almost completely fracture, and now it's angled through that. So this is actually, according to their definition, we can't really call this an atypical femoral fracture. That would be excluded because periprosthetic fractures are not in the definition. Having said that, this looks a lot like one to me. So that's just, we've had a couple of cases like that. So just be aware of that, even when you do see total hips. So, you know, the classic location that I'm sure you all know about and I've told you about so far has all been femoral shaft. There are cases of them occurring in other locations. So here's, this is from the literature. A colleague of mine from UBC just sent me one that was in the ilium, so in the pelvis. So that has been reported in the literature. And here's one, an ulnar. That looks like a lot of, like an atypical femoral fracture, likely, with the appropriate history. I find a lot of times when they're more complete fractures like that, it causes a bit of a conundrum. It's hard to know necessarily, but when they fix them and they put the pieces back together, that's when you see that lateral cortical beak, which may or may not be evident when they've completely fractured. Okay, so we're going to move on and talk about the different imaging modalities, because these can be seen on many different imaging modalities, pretty much all of them. I'm going to show you examples, and it's important to be aware of them because you may not be looking for these, and that's what happened in a couple of cases here. So plain films, of course, are the mainstay. You know, patient comes in fractured, and here you go. So this is a good example. Someone might just describe that as, you know, an oblique fracture through the femur. You can imagine if you put those pieces back together, like a puzzle, that's when you're going to see the lateral cortical beaking. So I think a lot of times we weren't calling these. We didn't even notice that these were atypical femoral fractures until now we actually know what these things are. But you can see there how it just sort of flares out just at the level of the fracture. So that's a key feature of this. Here's an example, and you're going to see this one because this is the one that sparked my interest. This looks pretty normal. This was called normal, but if you look very, very closely, and we'll say the lights are on, hard to see, we'll have lots of excuses why we can't see that. But in any case, blow it up, and there it is. And I'll show you this case and what happened with this one, and that is an atypical femoral fracture there. I'll tell you the story on that one. So what happened with this patient, this is the case I showed you at the beginning. Patient came into the emerge. The history we got was rule out OA, hip pain rule out OA. The x-rays were done, called normal, and this is true story. Patient was sent home. There's a CT, which I'm going to show you in a minute as well. Patient was sent home, follow up, family doctor, walked out of the hospital, tripped on the way out of the hospital. These are about 2 hours apart, these two images. So they completed the fracture, got back into the emerge. And of course, this sparked a lot of interest amongst the clinicians, amongst the radiologists, amongst the emerge staff, amongst a lot of people. And so then we presented this at M&M rounds, and this really sparked my interest in this topic. And that's kind of what caused me to really get involved with this, because I think this is absolutely a hard case to see, but in the end of the day, I also realized that a lot of us actually don't even know about this as radiologists. This is something relatively new, and we do need to know about this, and we really need to make sure we report these things when we see them, even though they might be subtle, and we need to know to look for them. And also the clinicians need to provide us with some more history. This patient was on bisphosphonates. That question was never asked. The history of osteoporosis was there, but they didn't ask. So there's a two-way thing that needs to happen here. So just moving on, I'll get more to that case in a minute, but here's another example, different patient of an atypical femoral fracture. You can see the lateral cortical beaking, and you can see that little lucent line transversely through the cortex. So here's that same patient. What's the most significant abnormality? So here's the case. In retrospect, it's even hard to see, but I'm telling you that that's where it was. It's right there. There's the tiniest little cortical beak there, tiny. And there's the plain film, as I mentioned, and that's how it was fixed, so with an intramedullary rod. Yeah?
The second time when she walked out of the emerge, there was trauma.
She tripped and she fell. So it's
there was a reason to have fracture.
Yeah, so there was minimal, so the case definition is minimal or no trauma. So that's the problem. They are at risk though. So it's she just tripped, and it was like a trip. It wasn't a fall. It was like she tripped. And so it was a minimal trauma that happened. But so that was an interesting situation. So here's another example here of just this is from 2013, August to November, and what looks like fairly benign kind of cortical thickening, and the patient comes back in not too long after that with these completed fractures. And of course, the morbidity when they do this is much different than if we can do something here to try to prevent that from happening. So that's kind of what we want to make sure that we call this and we alert. And I'm going to tell you a minute about this ALERT program that's sort of been started, that we tell the clinicians and get them to think about and correlate whether they're on bisphosphonates. So CT is another imaging modality that we use to assess these. And sometimes the plain films, you just can't see the darn things. In any case, I'm telling you that it's there, and we know that because that's the bone scan that was done to help us guide to where the abnormality is. And on the CT, though, we do thin slices, 0.6 millimeter, and we do reformats through it. So we're looking specifically there. In this particular case, we had some idea of where we were trying to find the abnormality. But on CT, you can certainly see these things quite well. Doing the coronal reformats, of course, is really imperative to be able to see these fractures. So there it is there. I'll just mag that up for you a little bit. So MRI is certainly not the first test that we would use, but we certainly can see them. And you might be doing an MRI for another reason. It might be rule out quads tear, rule out something, hip pain or whatever. It might be not clear because they do have these sort of vague symptoms. So what you need to do is really have this on your radar and think about it. And so you can see here that there is this sort of cortical thickening, lateral cortical beak, and they usually present with this little bit of edema around the periphery on the at the soft tissue side of it, or just on the periosteum. I think that's probably just the reaction there. So that's what they look like on MRI. And again, it's just to really to be aware of it. We don't typically do MRs just for this. It's one of my colleagues has done a whole cost analysis on it. It certainly is not the right imaging to start with. So bone scan is done a lot as well, and it is a helpful modality. I've already showed you a bunch of cases of bone scan and how it is helpful, particularly when there are cases that have this sort of diffuse periosteal thickening, and it really does help us to determine where exactly, if there is actually a little micro crack or something that we may have troubles finding on plain film or CT. So it really helps to guide us as far as knowing where to look. Here's just another example. This diffuse periosteal reaction in bone scan really helps to identify the locations, and it shows us the bilaterality in this particular case as well, which is helpful. So bone density, again, this is certainly not the imaging modality of choice by any means, but just so you know, you can see these things on bone density. So again, it's just to be aware that it might pop up when you're not looking for them, and there it is right there. So it's pretty classic. You'd obviously want to recommend that they have dedicated plain films to further evaluate that. So here's a case that came in to me. I was on ultrasound, and it was to rule out a quads tear. And so I'm looking around. It was a 78-year-old man, and I was looking around, couldn't find anything. And then I went and I just sort of decreased my focal zone, and I looked and I go, okay, that's a little bump on the femur. And so it was nice because the patient was right there. I said, are you on bisphosphonates? Yes. I said, okay, let's get an X-ray. And so you can see the little bump there. So we got an X-ray, and there it was. So, and I'll just flip that around there so you can see the correlation. So again, if we're not aware, we won't find it. But, and that certainly was not what I was looking for. But as soon as I saw that little bump, it was pretty clear to me that that was likely the cause of the pain, and there was no quads tear. So just again, to keep it on the radar. So we're going to talk about management, and so these have been managed in many different ways. The first thing the clinicians would want to do is to stop the bisphosphonates or the denosumab. That's the first thing that is done. So that's really just so stopping the medication. So they put them on a holiday. They take them off the medication, and they put them on what's called a bit of a drug holiday. They limit weight bearing, and it's a little bit variable because they don't know. Sometimes, I mean, I've showed you some cases of some really subtle ones that have gone to complete fractures, but we also have cases of ones that look like they're about to fracture, and they treat them conservatively and they heal. So it's hard to know and hard to predict which ones are going to fracture or not. But they do want to limit the weight bearing and make sure that the patients are aware that they don't trip and fall. They have to obviously be careful of what they do. They'll put them on teriparatide, which is an anabolic agent associated with enhanced fracture healing. So they stop the bisphosphonates, they put them on this, and they try to heal the fractures as much as possible, remembering that they have delayed healing, and so it's a bit of a problem. So what some of the thinking is now is atypical femoral or no atypical femoral fracture, patients on bisphosphonates should go on some sort of drug holiday, because it's been, some of the studies I showed you there, you can see the risk was at around 5 years, starts to go up. So, they say around 5 years, put them on a drug holiday, let's everything get back to normal again, and then we can put them back on the bisphosphonates. So that's what a lot of the clinicians are doing now, and that's how they're being treated. Interestingly, the one I showed you, the ultrasound, that guy I was able to ask, I said, well, how long have you been on bisphosphonates? 7 months. So now he didn't completely fracture, but he definitely had the changes already. So, and in our studies that we've done, it's quite a spectrum before they have these atypical femoral fractures. So they say 5 years, but we've seen them much less, and we've seen them much more delayed. So it's really hard to know what exactly to do, but it's a bit of a guess. But it's just sort of where they see the trend starting to increase. We have already talked about the importance of imaging the contralateral femur. So that's the next thing you do. So you see that on the left, okay, that's it was fixed obviously with an intramedullary rod there, but look on the right. So that right one is at risk. So, so that's definitely important, and that needs to be monitored. So there's some debate about whether they do surgery. Well, for sure for the complete ones, they're going to have to operate on them for sure. But there's some debate about prophylactic nailing for the incomplete femoral fractures. And I don't think the jury's out necessarily on how to best treat these. As I mentioned, doing those things with stopping the drugs, putting them on the paratide might actually be the best thing to do, and monitoring them carefully, knowing and just really educating the patients about the risks and making sure that they're aware and they take precautions. But when they do fix them, so here I'm going to show you some examples, like different surgeons will do different things. Here's an example, incomplete atypical femoral fracture. It's a little bit hard to see, but there is a lucent line going obliquely, inferiorly across the femur there. They've treated this with a DHS fixation, so that's one way to treat. An intramedullary nail, this is the one, and you'll see that this is the one that's most commonly done. Here's a patient, again, an incomplete atypical femoral fracture, intramedullary nail, and it has healed nicely over time. So blade plate, right here. So this is a patient who had an intramedullary nail, delayed fracture healing, started to fail. You can see the screws are fractured there just where I'm pointing it out. So they removed all of that as much as they could. They left a little screw fragment in there, and then they put this lateral blade plate. So things were going along, we thought, okay, and then that fractured. So, you know, this is the problem with these fractures, is they get into these complications and they just don't heal well. And then the patients, you know, it's hard for them. They have to be like non-weight bearing, and it's hard for them over time to do that. So, but this is a big problem, is the hardware complications. So we did a project. We looked at all of the hardware complications that we saw, and hardware failure occurs in up to 15% of atypical femoral fractures. So that's a lot, but it is less common with intramedullary nailing. And so we did when we looked at all of the cases, the intramedullary nailing was the one that seemed to do better. So so we presented this work at RSNA a few years ago. So here's one with a DHS, an intramedullary nail. It fractured right at the level of the atypical femoral fracture, and it was removed, and they put an intramedullary rod in. You can see there's abundant callus there. It eventually went on to heal. But this is like 2 years later. These take a long time to heal. So in our study, like I said, we found that the hardware failure was less common with intramedullary nailing. So just always remember the delayed healing. We need to keep an eye on these, and there is hardware failure. So it's interesting what's happening now. There's, you know, lawsuits now starting about all of this, and some of these, you know, this is an American one here. Have you suffered bone injuries after taking Fosamax? Contact the lawyers and get your case evaluated. So that was an American one. So then I'm on the plane going to Whistler last year to a conference, an MSK conference, where I was giving this talk, by the way. And sorry, I was on my phone on the airplane, so it's not the best image where I was like, oh my goodness, I can't believe this. Anyways, have you ever used Fosamax or Fosvenus? I don't even know, I guess that's another name for it. I'll just, so what it says here, if you are a patient, have suffered, if you've been on these medications and you've suffered, it says the other thing is they get osteonecrosis of the jaw or an atypical femoral fracture, immediately review. We can this full legal notice, and we will tell you about your legal rights. And the interesting thing is that this is London, Ontario. I know, I actually didn't, when I was reviewing these slides again, wow, I forgot about that. That's London, Ontario. So a class action claims administrator, P.O. Box 3355, London, Ontario. So it's not just American, you know, you hear about these things, but this is Canadian as well. So, you know, I don't know what's really come out of these things, but certainly the lawyers love this kind of stuff, right? So, anyhow, just so you're aware, that's kind of what's happening. But just to bring us back to a little bit of the literature here and some more recent things, and I think really there's sort of a group of us that are interested in osteoporosis, and we're really trying to get this message out and really trying to, I mean, it's not, the imaging's not complicated, there's nothing too fancy about this, but the point is that these patients can certainly have high morbidity if they're not identified. So here's a chart audit that was published in the CARJ 2016, and this is some of the people there are from BC, and the bottom line here, so radiologists diagnosed atypical femoral fractures in 1 of 24 patients with characteristic radiographic signs of atypical femoral fractures, so not doing very well. 19 of 24 patients had adequate imaging of the contralateral femur, so they weren't all imaged bilaterally, and they were only commenting and putting it in the reports in 1 of 24. So we need to get better, that's for sure. That was in their chart audit. So I got involved with an internist who was really interested in this as well, Dr. Aliyah Khan at McMaster, and she was really, from the clinician perspective, really wanted to get this out. So I was invited to write a letter to the editor, and this was also published in the CARJ in 2016. And it's really, she really got this ALERT program going. And the point here is really what is helpful for the clinicians to be included in the report and how we can help them. And so again, this is an internist who wrote this letter, and I just happened to be part of it. So it's interesting because they really want to know and they want us to help them. So this ALERT program, so these are the important features of it. So we want to include findings of atypical femoral fractures in the concluding comments of the report. They need to know it, they need to see it, it has to be pretty clear. They want a highlight of the association of atypical femorals with the use of bisphosphonate. So I always say, you know, this kind of fracture is typically seen with bisphosphonate use. Please correlate clinically or something like that to certainly spark their attention, and recommend x-rays of the contralateral femur. So those are the things we want to put in our reports to make sure we can help the clinicians. And remember, some of these could be, these are not necessarily osteoporotic specialists referring them. These could be family physicians or people who may not also know a whole lot about that. That's why we need to be pretty directive about this until it gets a little bit more out there. Incomplete atypical femoral fractures characterized by periosteal thickening and a lucent line known as beaking or endosteal thickening of the lateral cortex. So we've already been through that, but that's how they would like us to make sure that that is clear in the report. Report these findings as a potential incomplete atypical femoral fracture and mention that association. So they want that in there. They also want us to educate the technologists to include the bilateral femur x-rays if the indication is to exclude an atypical femoral fracture. So that could be something maybe your technologist can, if that's the history, you can maybe talk to whoever it is you need to talk to at your hospitals to just allow them to do the other side. That may be something you want to just have like as a standing item. If images are normal with a history of thigh or groin pain, they suggest a follow-up in 6 months and exclusion of the other causes of thigh or groin pain. That's a bit more from the clinician's perspective of that. And you know, they're of course going to have to follow that and order the imaging. So this is this case. There's one more little piece of information with the case that came in that to emerge that day. And here, there was a CT was done. So a CT was done just to also exclude, you know, OA or something else going on. The problem with the CT, because we didn't have the history, our regular, it was done as a CT of the pelvis, by the way, not of the hip. So the field of view, that's the field of view. That's as far down. I cropped it down to just the right side, but it was an entire pelvis. So the field of view didn't even include, there's the fracture, there it was, right, probably starting about there. I actually measured it all to see where it was, but it was just on the edge. Because we didn't know what we were really looking for, we were going on a bit of a fishing expedition, we didn't include far down enough. So that's the other thing to do, is to educate the CT techs to make sure that we go down low enough. Again, you've seen this before now, there's the fracture, and that's how it was treated with an intramedullary nail. Okay, so we're gonna revisit those, that's the case I showed you. Now we're just gonna revisit this one second question I asked you at the beginning, which was, how is this fracture likely to be treated? DHS fixation, intramedullary locking femoral rod, a lateral side plate, total hip arthroplasty, or conservative with no weight bearing. So based on the research that we did, this would likely do the best with an intramedullary locking femoral rod that will have the least likely rate of complication. And there it is, that's how this one was treated. So just a few take-home points about atypical femoral fractures. So the typical atypical femoral fracture is Subtrochanteric or diaphyseal, transverse or short oblique, so transverse through the lateral cortex and then taking an oblique course as it is completed across to the medial side. It has that medial spike, a lateral beak, and it's often bilateral. So it's important to know that case definition for the diagnosis of atypical femoral fractures and to know the typical imaging features. I pretty much showed you the spectrum of imaging modalities there, so you can see this on pretty much everything. And again, to image both femurs. When they have hardware fixation, we definitely need to watch for delayed healing and for failure. Really look for some subtle bending of screws, little cracks in screws. We've definitely seen some subtle hardware failure that occurs in these patients. So proper reporting and follow-up is also key to reduce or decrease the morbidity and mortality in these patients. And there's the ALERT program there. And just to also reiterate what I talked about, I'm showing you some completed fractures here that are obviously a concern, but just remember that treating with bisphosphonate outweighs the risks of these atypical femoral fractures if we're doing all of these things to minimize the risk. So that brings me to the end of my presentation.